you so much to everybody for coming to the webinar today. We are going to take just a minute to let more people get in, and then we will get started. Thank you for joining us for this installment of Root Cause Coalition's How To webinar series. My name is Rachel Carlson, and I'm the Membership and Engagement Manager at the Root Cause Coalition. Before we get started with our presentation, I just want to go over a few logistical items for the webinar. Attendees will be in listen-only mode for the duration of the webinar. This webinar is being recorded and will be available to view at rootcausecoalition.org later this week. Our panelists will be taking audience questions. If you have a question during the presentation, you can use the question box located usually on the right side of your screen and type your question into the question pane. We are so excited to have our esteemed panelists join us on how to use data to deploy resources to vulnerable populations for COVID-19. At this time, I would like to pass it off to Trenner Williams from Socially Determined.
Rachel, thanks so much. Thank you all for joining. These are busy, unprecedented times, as we all know. So the opportunity to speak to you all and share some of the really great work that's going on in the state of Maryland and led by the Task Force for Vulnerable Populations. We couldn't be more excited to be able to do that. I'm also pleased and proud to share the stage and hopefully a lot more than me talking, but Ashley Perry, who is our Chief Solutions Officer at Socially Determined. I serve as one of the founders and as the CEO. By background, real quickly, I'm a family doc, and as I like to say, the son of a social worker. So this work is important both personally and professionally. And incredibly proud and pleased to share the stage with Dr. Susan Mani. Susan is the Chief Population Officer at LifeBridge Health and is the lead of the Task Force for Vulnerable Populations for the state of Maryland. So we're excited for this opportunity to share our story with you all. We hope that you all will take advantage of the ability to ask questions throughout, so please use that question area, as Rachel said. We will have time as well at the end to be able to take those questions, and Rachel will read those out and we'll do our best to answer them. So we're going to go through and tell the story, and then we're actually going to show some of the platform that the state and resources across the state are using. Susan, I'd love to turn it over to you and to kick us off.
Great. Thank you, Trenner. Thank you, everyone, for joining this afternoon and this wonderful opportunity to share this. And as Trenner mentioned, we recognize everyone is extremely busy and thinking through novel solutions and how to manage during this crisis and pandemic. So I'm hoping that some of the story that we share today will resonate and also generate some thoughtful discussion as we continue to think how do we move forward in the state of Maryland. So to give everyone a sense of how this journey started, Maryland created a task force to assist in planning for surge and specifically to address our vulnerable populations. There was a great deal of concern that certain populations would be disproportionately impacted from COVID and have a higher likelihood of severe disease and mortality in the state. From the national and the international data, we could see that people with certain underlying chronic conditions were certainly at higher risk, but we were also very concerned that those with significant social determinant of health needs, frequent utilizers of our EDs and acute care historically in non-COVID times, or those who might find it very challenging to meet the social distancing guidelines due to their unstable or congregate housing situations, would be especially vulnerable during this pandemic. And this, of course, in turn has a significant impact on the capacity needs of our health system. Trenner, if we can go to the next slide. To give you an idea of that impact, when we considered our homeless population, clearly vulnerable for all the reasons I mentioned earlier, we knew that we had over 6,500 who were considered homeless in Maryland at that moment in time, whether it be sheltered or unsheltered. And we also knew, looking at other cities, such as hearing from Boston or states like California, that what they were finding was greater than 40% of the populations that they were testing in homeless shelter really were found to have infection rates at the time. We also knew historically homeless populations have a 1.6 greater relative risk of death when you take a look compared to the general population due to a lot of chronic conditions that were unmet. And we were also seeing, even from the limited national data for our homeless, that many were requiring a greater than 10% ICU level care. So when we started to apply those kind of numbers and that kind of historical data to our state, we were taking a look and seeing that we had more than 300 ICU beds or ventilators that would be needed if our homeless population became significantly ill from COVID. Now, it's one thing to say 300 beds across an entire state, but we also recognized as for our homeless populations, we knew that they were also geographically clustered in certain counties over others. And so now we were talking about 300 beds over a much smaller health system or hospital population. And quickly we could see how this could overwhelm a number of our health systems, despite a lot of the capacity and planning that was taking place. If we can go to the next slide, please, Trenner. The other major consideration that we needed to take into account as a task force is that historically, as this group knows, our vulnerable populations are supported through individual groups or a patchwork of cross-sector partnerships. And often that support is done on the ground. It's done in the community. It's done in community locations, in our streets and in people's homes. But what we were seeing from COVID was that it was having a significant negative impact on our traditional care delivery model. We couldn't go into the libraries or the churches in the same way to provide education. And what we were finding was many of our partners, especially our smaller community-based organizations and others, significant staffing issues or concerns about having staff go home to home or door to door and being a vector potentially for further transmission. So knowing all of this, we couldn't necessarily rely on the same kind of framework that we had previously. If we can go to the next slide, please. So our task force was created bringing together multiple diverse stakeholders across the state who were very well versed in understanding the unique needs of our vulnerable populations in Maryland. And as you can see here, you can get a sense of the depth and breadth of the different kind of groups we were bringing in together. This, by the way, is not all of the different folks that we have actually touched and been touching through the task force. We have been working very closely with our payer groups. We've been working closely with all of our health systems. We've been, and Trenner will talk through, we're working very closely with our CRISP, our HIE, and a number of different groups all together. We can go ahead to the next slide. I'm not going to go into a great deal of detail of this slide. It's here certainly for everyone to see, but these are the specific deliverables of the task force and how we ensured that our work was both informed from the local ground level operations, but also our obligation to deliver on statewide resources based on the needs we were hearing from those local coalitions. And it was pretty clear to us from day one that the first order of business was to be able to provide actionable data to all of our partners around our vulnerable populations, knowing that potential impact of morbidity, mortality, capacity, so that whether it be a health system, a public health agency, a payer, a provider, community organization, that they could proactively outreach and serve our most vulnerable populations so we wouldn't get those kind of negative outcomes or the impact to our capacity. So my very first call from this task force was actually to Trenner and to ask him to help us get exactly that kind of actionable data to our stakeholders. So Trenner, I'll have you take it from there.
Awesome. Thank you, Susan. And I think a really thoughtful description of the why and the what. And so with the state of Maryland leading in that way, and so happy that Susan did reach out. The good news, and just to give you everybody on the phone a tiny bit of background, so we are an analytics company specifically focused on social determinants of health, and a combination of healthcare and public health leaders, data scientists, and software and analytics experts. We had been in the business and are in the business of being able to quantify social risk, help organizations visualize what that means for the people that they have responsibility of caring for, and then being able to act upon that data. In pre-COVID times, that work really centered around how do we understand economic instability and food insecurity and housing challenges or transportation barriers, health literacy. And what we were able to do, fortunately, is be able to transition that work and add in a view as we think about social determinants of health and social risk for COVID-19. And just to maybe level set everyone, and certainly the Root Cause Coalition, there isn't a better organization across the country and the participants, right, who understand this space better. But I thought for you all, and I think a couple of these factors are incredibly important. So when we talk about social determinants of health, understanding those conditions across a community, again, whether those are homeless shelters, locations, senior living facilities, grocery stores, access to healthcare, the conditions, right, that are likely to impact the health of a community, and really think about that as social risk exposure. An example might be living in a food desert. Social risk, when we think about the social risk, those specific conditions are based on my personal attributes as well as my location in a community, my relative distance to resources and that availability, as well as, again, my own personal attributes and conditions. And so social risk might be in regards to food, like living paycheck to paycheck and struggling potentially, right, to put healthy food on my table for myself, my family, and others. And social needs, just even with greater specificity, actually experiencing the need, that specific social need, and how that impacts health. So at the end of the month, where we are right now on April 30th, and many of our folks, right, in vulnerable populations, unable to afford healthy food that month. So again, just as a level set, and so when Susan and the task force came to us, it was important for us to understand, I think, and think about social determinants of health at the community level, social risk at the person level, and then how that might impact their specific social needs. When we initially talked, and when we think about the pandemic phases and the response period, the initial phase where we are right now is that response. And there we talk a lot, Susan even referenced some related to a medical response. Like, how do we think about making sure that we have enough PPEs, ventilators, ICU beds, staff, medical staff and teams to be able to provide direct acute response. It's also a medical prevention response, and that is the work of the task force and the ability to identify those vulnerable people. We've talked about, like, how do we think about an avoidable rate? So how do we help prevent those people at highest risk? And the people, if they contracted COVID-19, would have the highest likelihood of severe morbidity, mortality, so that we can characterize those individuals, the communities in which they live, and then in a data-informed way, allocate resources at the county, at the community level. That being said, we also know and believe that we will move and rebound and stabilize. That is, we'll have clinical implications as our patients and the ones that the task force and the representatives across the state are touching now. The individuals, right, who've had to forego potentially some of their chronic care and disease management and what's going on. And social, right, the increased number of vulnerable people across all of our states and in our community, and the depth of which their severity of risk has increased as well. So we'll rebound and we'll figure that out collectively, and then move into recovery. Throughout each of these processes and each of these phases of the pandemic, the ability to use data to inform our strategies, our resource deployment, the investment that we make across each of our communities, we believe is vital to success and thriving. And so now 7 weeks ago, as the response or as the pandemic was increasing across the state, we took a scientific approach to better understand what risk looked like in communities and at the person level, right? So recognizing, and again, we know that we continue to get new data both in the United States and across the world, but that indicates right now the disease process and the severity of risk increases for our older aging population, especially those with pre-existing chronic conditions. And as Susan said, we believe, and I think it has been demonstrated certainly across the United States, that the risk posed by COVID-19 will be exacerbated, right, increased based on for those individuals who are facing elevated social risk, such as housing instability in our homeless population, not just those homeless, right, but those people that are living in congregate low-income housing, food insecurity, financial strain, and then for organizations and decision makers in government and health systems and our payers and public health and public safety need accurate information about their community and the individuals. And so we probably couldn't state this strongly enough, how coordinated and how so many different leaders across the state are necessary to be able to do this work, right? It started at the state level, but their willingness and ability to reach out immediately to Dr. Mani and that team at LifeBridge to be able to take a leadership role in this. On the left-hand side, the MCOs, so those responsible for supporting some of the services and care for our Medicaid population, the roughly 1.6 million Medicaid members across the state. Incredible partners like Care First, who has both a large, dominant commercial position. So most of the individuals across the state have Care First as their primary insurance, and they also help serve the Medicare population and now Medicaid. The county health officials across every county and their participation were unbelievable. And last and certainly not least, one of the reasons I think that we've been incredibly successful in such a short time frame is the work of CRISP, who's the statewide health information exchange and been in place for well more than a decade. But the ability to extract person-level data that Ashley will talk about in a second from the state appropriately in a secure, thoughtful way, deliver that to our team inside of our platform, and then be able to take those outputs that Ashley will describe and disseminate them to the right party so that they can act on them. Again, invaluable. And so as you all across the country are thinking about the different partners, this is, I think, a good exemplar of what's necessary to be successful. Ashley, if I can turn it over to you.
Sounds great. Thank you, Trenner. So as Trenner mentioned, it's socially determined. When we think about social determinant of health risk, we think about it at those three levels that he talked about. So social determinants of health at the community level, social risk factors at the individual level, and then social needs at the individual level in any given time. Our team of data scientists and subject matter experts at Socially Determined applied a similar framework to the way that we started thinking about assessing COVID-19 risk as part of our work with the task force around this. And so we started at the community level, developing a COVID-19 Social Susceptibility Index that looks at a variety of community level factors to assess risk across the entire state and then within specific geographies and neighborhoods and communities. Those types of factors include things like the distribution of people of different ages and with different chronic disease burdens across different communities, crowding, both in terms of the density of homes and the number of individuals living within those homes, economic stress at the neighborhood level, as well as exposure potential. So we got some great information from our partners at the state around congregate living sites, congregate feeding sites, and other places where you could have potential risk of exposure, as well as infrastructure within the community to support the response. So all of those factors are included in our community level view of social susceptibility around COVID exposure and the potential severity of symptoms for those who are exposed. Similarly, at the individual level, we developed a vulnerability index that includes all of those community level factors but also incorporates individual-specific factors around age, chronic disease burden, and geography that allow us to have an even more precise assessment of potential COVID risk for the individuals that were included in the data sets that we received. And I'll talk more about those in just a minute. But both at the community level and the individual level, we're able to use all of those different factors to generate a risk score, which is a 1 to 5 score in which 1 indicates little to no risk, 5 indicates severe risk. And the way that translates to the maps that you see is that the darker color correlates with increased risk. So as a starting point for this analysis, we were able to generate the community level risk scores for the entire state and visualize that to our partners on the task force, and then pull in individual level data to assess vulnerability at that level as well. And then finally, just to complete the analogy from the prior framework, we are also getting data on a regular basis around testing so that we can understand at any given moment how many positive cases are we seeing statewide. Next slide. So in terms of our approach, as Trenner mentioned, we were very fortunate to be able to pull in great data from a number of different partners. That included individual level data from both CRISP and Care First, representing over 2.6 million Medicaid and Medicare lives across the state. We pulled that individual level data into our analytic platform, which is called SocialScape. It's a secure cloud-based platform, HIPAA compliant and high trust hardened. So we're able to analyze both PHI and PII safely within it. And it allowed us to fuse that individual level data around clinical considerations, demographics, and geographic factors for those 2.6 million individuals, and fuse it with our community level contextual data around both social determinant risk and COVID-19 social susceptibility at the community level. And then once we've done that analysis, we're able to render the results of it back to our partners at the task force and all of the other stakeholders that are involved in the response statewide in a number of different ways. And that includes geospatial visualizations of risk at the community level, which we're going to show you more of in just a minute here, proactive identification of the highest risk individuals by statewide and by particular partners. We can do some custom visualizations of risk distribution for the state, for particular local county health officials that are trying to make decisions around resource allocation, or for individual practices and manage Medicaid plans. And then finally, we haven't got there quite yet, but we have the ability to do some impact evaluation down the line as well to understand the impact that all of this work had in mitigating risk across the state and within particular populations. The reason why this is important is because, as Susan mentioned, there are a number of different actors across the state who are ready to bring to bear resources and staff to try and mitigate COVID risk across the communities and populations statewide. But in order to be able to do that, each of those actors needs to have the right type of information that they can use to inform resource allocation and decisions that they're making on the ground. And that really starts at the state level, recognizing that the state wants to be able to look broadly and understand what the concentration and distributions of COVID vulnerability are statewide to inform some of the decisions that are being made around resource allocation. And to that end, we've created statewide visualizations of risk and custom analyses that tell that story and give state officials actionable information to make decisions on. Secondly, there are the 24 local county health improvement coalitions and local health officers across the state who are trying to make decisions for the jurisdictions that they serve. And to that end, we can use this type of data and analysis to provide them county level visualizations and analyses that can help inform those decisions, not just for the local county health officials teams, but also for a lot of the partners in those communities that have raised their hands and said, hey, we can help, we just need to know where we should go and what we should focus on. And so our ability to provide a common view of risk at that county level has facilitated some of those conversations and partnership opportunities. Thirdly, there is across the state of Maryland a robust primary care practice model specifically focused on providing enhanced care for Medicare beneficiaries across the state, and there's a great network of practices that are doing some innovative work there around care management. And so we were also able to use this type of analysis to generate risk scores for the patient panels for all of those practices. And we're able to leverage CRISP, the statewide HIE that Trenner mentioned, to share those risk scores directly back with those practices in a way that they can easily access them using dashboards and visuals that they already have access to today. And the practices are using that information in real time to understand which members of their panel are at highest risk and how do they take resources that are available within their practice today to proactively reach out to those patients and see if they can support them and help maintain them in their home and mitigate the risk of exposure or severe complications. And then finally, for the Medicaid population across the state, there are a number of MCOs who also have resources that they can bring to bear to better support their members. And so to that end, we generated rosters of the most vulnerable Medicaid members across the state, and we're able to share those directly with the MCOs so that they can provide them to their care management teams and do proactive outreach and support. So in terms of how we actually conducted the prioritization process, as I mentioned, there were about 2.6 million unique individuals in the data sets that we received representing both Medicare and Medicaid patients. That is far too much for even that relatively large list of stakeholders to take on. So our role at Socially Determined was to help stratify that list based on our multi-factor COVID vulnerability risk model, which again included factors like age, chronic disease burden, community level social susceptibility to COVID, and then also broad exposure to all of the SDOH domains that we look at, recognizing that factors like food insecurity and housing instability are going to increase risk for COVID vulnerability as well. Applying that model to all 2.6 million individuals, we identified about 900,000 that were at elevated risk based on our 5-factor risk model. So in this case, we've defined high risk as those who are a 3, a 4, or a 5 on that 5-point scale. And then we were able to translate those high-risk individuals into 2 different centralized delivery mechanisms. So the first is our SocialScape Explorer platform, which we're going to see in just a minute, but that allows you to see the geographic dispersion of those high-risk individuals as well as community-level risk. And then secondly, CRISP, as I mentioned, the HIE, which could provide those rosters of high-risk patients and views to the practices around their patient members who are at most elevated risk. So just to give you a practical example of how the numbers shake out on all of this, working from the original 2.6 million that we started with, there were 936,000 who were at elevated risk based on our 5-point scale. Of those, that translated to about 164,000 statewide who were at severe risk, so those who scored a 5 on our scale. At the county level, for example, in Somerset County, that translated to 771,000 individuals that were at severe risk for COVID complications. And then at an individual provider level within that county, there was one provider who had 43 patients who translated to a 5. So the goal of this whole process was being able to both on the upstream end appropriately prioritize based on vulnerability, recognizing that we need to enable all of the partners to make decisions around how they prioritize resource allocation and outreach efforts. And then on the back end, being able to filter that prioritized list appropriately so that we can share it with both the state, the local county health officials, individual primary care practices, and the MCOs to help each of those actors get the information that would be most relevant to them to be able to effectively roll out the resources that they have to mitigate the risk for those communities and populations. So that's the process and the journey we've been on over the last several weeks. At this point, I'm going to turn it back to Trenner, and he's going to show you what it looks like live within our platform.
Ashley, thanks so much. And again, I hope folks are taking the opportunity to think of questions. You can even start to put some of those in. We're going to quickly walk through what the platform looks like, and folks should be able to see now what is a map of Maryland, in case folks weren't sure. This is actually inside of our platform. I'll quickly orient everybody to that. We've got a couple slides right after this just to summarize, I think, some of the lessons learned and summary points about it, and then we'll have, I think, plenty of time for questions as well as we go through. So, orientation. Again, state of Maryland, this is our platform. So we look commonly at things like demographics, economic strain, as we talked about food insecurity, and I'll walk you all through a couple of these just to get an idea. So we have domains on top, including COVID. We have a menu on the left-hand side, the ability to look at resources and populations. And at the bottom right will be important for, as we dive into different counties and communities across the state, a legend that indicates risk. So let's just real quickly, just so folks are aware. So this is economic strain across a community. And what you'll notice is as we dive into closer to the ground, what was spread in as a single color across a county and across the state, a much more granular view. And so again, just to provide a little bit of orientation for everybody here, lighter the color, in this case for economic strain, the less the risk. And so 1 is little to no risk. As we get to the darker colors, and using our 5-point scale, 5, the darkest color is severe risk related to economic strain. I'll show food insecurity, and then I'll flip over to COVID and how our teams are using this, or how the task force, and the task force has access and resources across the state to the entire platform, not just to COVID. So we can look at things like food insecurity as part of that. Just to give an example as well, some resources that might be relevant here, like healthy or unhealthy food options. And so we have an entire resource map-based model, and so able to identify and see specific resources like the Western market that exist is there. So again, task force, county officials, and resources have access to that. Specifically related to COVID-19, and again, just to orient everybody to where we are. So this is Baltimore County here that I'll spend some time in. Again, same risk model, 5-point scale, where 1, the lightest color, is little to no risk. 5 is severe risk. You'll notice areas of gray across the county, especially as we get into more rural environments around water, where we've netted out land use that isn't used for residential purposes. So we don't score where people don't live, is what that means. So the task force has access to this. So there's initial value in being able to see, based on our COVID susceptibility index, where there are pockets of highest risk. That in and of itself is a little valuable. What becomes more valuable is as we think, and can we layer in resources, or again, in this case, maybe living facilities as part of that. So I'll show you one example. So senior living, congregate living for our seniors at risk because of both chronic disease and age, and the fact that they're in congregate living. So we've added, and this was directly as part of this, we did not have this built in to our map and to our model prior to the COVID risk, but assisted living facilities. So working with state representatives and access to that data, and so able to see assisted living facilities, senior living facilities, long-term care facilities, location, as well as capacity. I think it is the task force and manage in place teams that Susan can talk about are going out into the community. They have access to this information as well. Another example Susan mentioned, and I'll take off the assisted living, but we added in homeless shelters. So again, data directly from the state. We did not have this built in ahead of time, and able to see homeless shelters that exist inside of given community. And you'll notice that right now what we're looking at is at a county level. And so it's like if I go into a net new county, I'm able to see that information start to display there as well, and get all the way down on the ground and see very close, very granular, exactly where those locations are. So again, as different representatives across the state are thinking about their strategy and deploying resources, the ability to see that. A couple more points that I will make. The first of which is the ability, many of our partners are health system partners, and so I'll look at Howard General in Howard County. We have hospital catchment areas built in, and so this is really useful if you're thinking about the surge from a hospital standpoint, and able to see where there is risk across, again, in relationship to my hospital. The last piece that becomes, I think, the most valuable as part of this is identifying those individuals, as Ashley said, those 936,000 individuals with elevated risk because of their social risk factors, their age, and their chronic disease burden, specifically thinking about the CDC and World Health Organization guidelines and diagnoses that they've identified. So we have the ability to actually plot those individuals as well across the state. So whether we wanted to look, the red dots are representative of those individuals with severe risk, those 164,000, and again, get all the way down on the ground and see exactly where those individuals are. If we wanted to look at that, again, in relation to shelters, social service, or other, we have the ability to do that. We wanted to think about not just the severe risk. We were able to delineate high risk, in this case in orange, or moderate risk in yellow. And so from a density standpoint, the ability for task force and other members to see exactly where those people are, see clusters of those individuals, and be able to deploy resources more effectively, again, with a higher likelihood of impact. Susan, and maybe just before I turn it back over to you from a slide standpoint, any thoughts or questions, or maybe not thoughts and questions, but thoughts or uses of how the task force or other members might be utilizing some of the tools?
Sure, and I think, Trenner, I think, one of the major things that we were finding was, as Ashley mentioned, we have attributed lives that we've given out now to our payers and providers and health systems with their high risk lists. And there's always been this historical convergence of these groups. But now the kind of discussions that we're seeing is how can we use our unique perspectives and our relationships with our populations to address specific issues. So we've already recognized, and I'm sure many on this call have as well, that in our communities, due to fear about COVID, we're just not seeing that members in the community are even seeking appropriate clinical care right now with their providers, their hospital offices. So how can we address that together through an integrated workflow and a sharing of these lists? So that's much of the kind of conversation that we're seeing that's starting to spark, and figuring out how can we practically use this. I will tell you, I think another thing that we are seeing through this is this kind of data and sharing it with such a diverse group of stakeholders is that it's not just informing our collective impact strategy, it's actually driving it into brand new directions. We kind of call it a new normal. And another area that we started to see is that as health agencies and local coalitions started to look at those maps, as Trenner just showed, it was spurring this kind of conversation that in order to proactively start addressing these populations, because I think what everyone was doing, and rightfully so, was very much focused on the outcomes, the actual cases, and obviously thinking about the capacity in the hospital, all very, very appropriate for what needed to be done. But at the same time, we're now starting to germinate these parallel pathways of saying, okay, now to be proactive, because COVID isn't going to go away anytime soon. So what does this new normal need to look like? And we think not only is this going to have a disproportionate impact on our vulnerable populations, but the volume of our vulnerable populations will increase due to the economic impact of the pandemic. One concern that they had is how can we get a group that can go into communities safely, that can be a clinical member of the team, as well as address some of the social needs of the community. So Trenner mentioned the manage and place teams, and that came through a direct integration of this data in conversations with our health agencies and our local coalitions. It's really this group effort that the state now has put into place, which allows some of our counties to get resources around clinical members, as well as community health workers or social workers who can take these lists, as Trenner mentioned, work very, very closely with the local health agencies and health departments to proactively go in, do screening, testing, and also address some of the social needs that we know are not really being addressed at this time. So I think this is moving us towards just thinking about a much more effective care delivery model, and now thinking about the unique strengths of each partner in a way that we may not have always historically recognized. And Ashley, you want to talk through?
Yeah, so just before we pivot to Q&A, we wanted to just leave you all with a couple of reflections from our experience over the last 6 or 7 weeks working together, and some thoughts that we had for you all as you think about ways that you can undertake work like this in your own communities and with the partners that you're working with today. So the first is that innovative public and private partnerships are critical in helping to mitigate the existing public health crisis around COVID, and they present a real opportunity to bring together the unique skill sets, data sources, capabilities, and resources that are available and really needed to work, as Susan mentioned, in a coordinated and integrated way to be able to respond effectively to the current crisis, as well as what we know will be coming in the weeks and months ahead in terms of the secondary effects that we're going to see around the broader economic decline following COVID and the impact that that has on health and well-being in the communities and populations that we all serve. So think about the partners that you have at the table today. Think about other organizations that you could bring to the table and start to have conversations around what you could do together that would be greater than the sum of your parts. Second thing is that those of you who have attended other Root Cause Coalition webinars or the national summits, you know that conversations around data sharing and integration challenges are common. It's a pain point that we all feel, but the urgency around being able to respond to COVID creates a unique opportunity to overcome many of the barriers that have stood in our way historically around data integration and sharing. And so think about how you can expedite your way through those conversations and processes to get to a point where you're able to share data more effectively, both to support this immediate public health crisis, but also really to build a foundation for more integrated and collaborative data sharing structures going forward that are going to be increasingly important as we think about the next couple of phases of the pandemic. The other part that's been a big learning for us is that questions that the task force has asked us to help them answer, and the decisions that the stakeholders are making on the ground are evolving incredibly rapidly. Not even week to week, but day by day and hour by hour, those questions and decisions are changing. And so the ability to assemble an agile analytic approach and a partnership structure that allows you to integrate data effectively and rapidly, to be able to do rapid cycle integration and iteration of the analysis, and to get feedback quickly. And if anything, we've been getting a lot of feedback very quickly, but to understand, like, what are the questions that need to be answered today, and how do we use the data that we have at our fingertips to help drive those decisions? It's critically important, particularly in this moment where there's so much urgency to act. And then finally, and all of us have touched on this a little bit in our remarks, but we fully expect that the impact of broad SDOH risk exposure and individual level social risk factors are going to be exponentially increasing as a result of this crisis. And so as we collectively move forward as a coalition and as a community that's interested in mitigating the impact of SDOH risk more broadly, being able to understand what that risk looks like on the ground for the communities and populations and families that we're serving is going to be even that much more critically important moving forward. And so we can use this crisis as an opportunity to start building the right processes, structures, partnerships, approaches to do all of that work going forward as well. Before I turn it over to Rachel to facilitate any Q&A, Trenner and Susan, anything else you would add in terms of lessons learned for the journey that we've been on together over the last several weeks?
Susan, I'll let you start.
Sure. I will say that it has been extremely gratifying. While this has clearly been challenging times for everyone, I was telling Trenner at one of our conversations, it has been an incredible moving experience to see how many different stakeholders have really come together and sometimes put aside many of the historical barriers that can just naturally exist in this kind of ecosystem that we are all in, really to think about a greater good. And Ashley, you mentioned the pace of feedback, and I will say I think some of this, what we're also seeing is an incredible pace that this group has been able to maintain as a diverse group of stakeholders to make good better for our patients and our communities. So while this pandemic has been harrowing for many reasons, it has really laid down a framework and as Trenner likes to say, the train tracks that we can kind of see going into the future that actually will lead to something bigger and better.
Well said by both of you. I can't add anything that would be as valuable as what you said. So Rachel, maybe turn it over to you. I know I saw we had a couple questions already, but if you want to facilitate the Q&A part, that'd be great.
Yeah, absolutely. Again, thank you so much to our presenters and to everyone for attending today. A quick reminder before we go into the Q&A is that this session has been recorded and will be available to view at rootcausecoalition.org/webinars by the end of the day tomorrow. So if you need to leave early, or if you have a colleague you really want to see this, you will be able to share that recording. So let's go into some questions. The first one we have from one of our participants is specifically asking Trenner about, are there plans to adapt this work to facilitate contact tracking?
Yeah, and I won't be the only one to answer here, but I think the short answer is yes. And there are other parts of the state, obviously, that are working on this, and certainly hope that our ability, right, at that granular level, to be able to identify both places and people will be helpful. Ashley and Susan, though, do you want to talk about any of the specific conversations other than sort of the general yes?
Sure. So CRISP, as Trenner mentioned, is our HIE,
Yep.
and they are being utilized right now in the state, working very closely with our Maryland Department of Health around the contact tracing. So one of the conversations I know we'll be having through the task force, because we have a very close relationship with CRISP due to all the work with this data, is how do we start integrating these efforts? Because it's, again, I think a lot of the value of the data that we have is that proactive identification and outreach. And that's actually a perfect marriage as we think about the tracing efforts as well.
Great. So Rachel, I think we can go to the next one.
Yeah. So the next, for one of our other participants, asks, what have been the best lessons learned through developing and working with this task force?
Trenner, you want to go first?
Well, yeah, I think Susan and Ashley hit on many of these. One is not that one of the lessons I think is not to let historical barriers stand in the way to truly take advantage of this opportunity. It's been, as Susan said, I think extremely rewarding, like to be able to really be. We all talk about it, and I know, having participated with the Root Cause for a long time, like. We think about being person-centric, patient, individual-centric, but to see the different organizations come together, put a person in the middle, right? Because they have payer, right, relationships, you know, they're member from an insurance standpoint, they have patient relationships with primary care and other resources within a county, and to be able to see the requirement of all these different types of organizations to come together, put that person in the middle to think about how we all best serve them, their families, and in their communities has been, I think, just a great lesson. And to, as Susan said before, like to not be limited by historical barriers or previous challenges has been really important. Other things, maybe Susan, then Ashley would want to add.
I think you said that very well, Trenner.
Thanks. Ashley, anything?
Agreed.
Okay.
Another one of the participants asks about if you at all are planning on connecting with state community health worker associations and working with that group to begin addressing needs in highest risk communities.
Sure, I can take that one. One of the reasons we had the task force is very much we recognized early on we need a diverse group of stakeholders, because no one group has the breadth and the depth of really thinking about all of the aspects and partnerships that really touch the needs of our vulnerable populations. So one area that we have been working on based upon these teams that I mentioned earlier, which was the clinical as well as teams that are serving the social needs of our communities, is exactly that. We've been working with our local health departments and agencies to address at a local level some of our community health workers and integrating them into this work. And in fact, integrating them not only with the teams, but how do we make sure that they are also part of the partnerships. And what we're finding is that that partnership already exists at a local level. And what we want to do is at the task force level say, is there any other way and any other additional stakeholders that we need to start making sure there is a leadership level communication around? I think as we think about this in phases, we have really been running at 300 miles per hour over many of these things. And I think now that so much of this framework has been put in place, it is getting to those operational logistics and tweaking some of these things for some ongoing. And phase 2 very much is about how do we incorporate even more stakeholders into our team to think about all of those facets thoughtfully and deliberately as we continue to go forward. I think as a task force, we recognize our work has not at all been complete. It has just generated even more questions and needs that we need to think about answering.
Well said.
Great. Another one of our participants asks about, does this data help to maybe inform what type of evidence-based solutions or interventions and pathways might be best utilized going forward?
Ashley, you want to take that, or you want me to?
I'll start, Trenner, and then feel free to weigh in as well. I would say yes, but one of the interesting lessons learned as we started to hear feedback from the recipients of the information, whether it's care managers at the MCOs, whether it's folks at the practice level that are picking up the phone and calling the most vulnerable patients, whoever is doing that outbound outreach and trying to support those vulnerable members and patients in place. What's been helpful for them is to understand not just the context of COVID vulnerability, but also the other factors that could be influencing that. So for example, reaching out to someone who may be food insecure and have transportation challenges. And so the conversation around how that vulnerable person could be best supported to maintain in place and stay in their home and avoid exposure, it has to be about more than just COVID, right? It also has to be about, do you have access to the prescriptions that you need and the food that you need? And are there ways that we can support those needs as well to help people shelter in place? And so all of the pieces of the data, not just the COVID vulnerability, but the social risk exposure, the resources and assets that are close to them in those communities, all comes to bear when you're having conversations around how to best support that individual from not just a clinical perspective, but a social one as well.
Yeah, and maybe just one quick addition. Maybe just a quick addition in that what we keep talking about too is sort of the go forward. And so I think food insecurity as an unfortunate, really important example with the number of hungry individuals and families across the state and across the country increasing, but being able to layer in as an example, like congregate meal sites. And I speak as the father of, 2 elementary school kids, appreciate what large percentage of children get their meals from school. And as across the country, that has changed. So being able to utilize the information, the data, being able to plot that on the map and be able to provide that information as we think about new congregate meal sites and what that means for individuals. So I think that ability was the reason that we provided broader access to the platform, not just to COVID risk, but to other social risk factors, but knowing that information now and going forward will help inform those intervention strategies with much more specificity. Susan, any additions to that?
No, I think that's exactly right, Turner and Ashley.
Okay.
Another question we have asking a little bit more about sort of the initiation of the task force, and was it in part the role of the sponsor who initially initiated, and sort of what going forward was the role of the sponsor, and who sort of was taking the lead throughout and within the task force?
Sure, I can answer that. So Dr. Haft has really been the sponsor of this task force, and because he is part of the broader task force at the state level, thinking about the surge planning, that's really where his role has been. And the task force really came about because of multiple people bringing forward the concerns and thoughts about the vulnerable populations. And frankly, that's how it kind of germinated. It's sort of a lot of different people thinking about this and saying we needed a forum. And I think Dr. Haft recognizing it and bringing the group together.
Great. And then I think we can probably do just a few more. So if you have any last minute questions, please submit. So our next question is about what are sort of the next steps moving forward. This is an ongoing issue we talked a little bit about before, the different phases, but what comes next from this data and this task force?
Turner, you want to start?
Yeah.
And then...
I'll start and then kick over. Yeah. So we kept talking about sort of the ongoing need. Part of that probably gets to one of those previous questions about contact tracking, being able to look at where there is increasing risk, what our numbers look like across the state in terms of people with active disease as part of that. That being said, if you remember one of the earlier slides where we talked about response, rebound, and recovery, as we move into this next phase, right, and our hospitals open up more for, again, the word elective procedure it's always nice to say, especially when it's not your procedure, your surgery that you're going through. So it doesn't feel elective to a lot of people, but being able to understand sort of how we manage risk of these vulnerable individuals as they get reintegrated back into the care that they need, and they get reintegrated back into their lives. Again, we're going to have a greater number of people who are food insecure. We're likely to have a significant increase in the number of people who have instability in their housing situation. And I'm not just talking about our homeless population, but a lot of people, again, are going to struggle related to rent, mortgage, and other things like that. So being able to use the data and likely starting to use other data sources to be able to get even more granular, identify greater need. And then going back to the last question, what you want all of this to do is to help guide with more specificity and precision what activities, both for whom, where, and what you're going to do. And so I think we'll work together as a task force to be able to do that, continue to add net new data sources in so we get more and more precise with how we can support people.
I think that's very well said, Trenner. And this ties in, I think, that for the person asking the question, very much with where we are now as a task force. As we have been sharing this data with so many different stakeholders, what we're realizing is these unique perspectives and solutions that are coming about because you have exactly that, diverse stakeholders looking at this and metabolizing this data, so to speak, and recognizing how they could utilize it in different ways that is just, it's just fascinating. And as part of that, there's a conversation that we'll be having as a task force is, we considered very specific stakeholders based upon some very specific needs we saw. So whether it be with our payers, our providers, our health systems for those attributed lives risk list, as Ashley had mentioned, to our health officers and their local coalitions. But I will tell you, as we start sharing that data and that data starts to be seen by other groups are starting to say, you know what, this is incredible because we can start to think about planning and resource allocation in ways with this pandemic from an economic standpoint, from a business standpoint, above and beyond our population management. But at the same time, that's very integral as we think about the health of our populations and what resource planning needs to look like in the community. So one of the major conversations is going to be, how do we take this halo of data and the transparency of this data, and how do we start to expand it? And I think very much what Trenner is saying too, and start integrating it with some of the other data that exists out there, whether it be outcomes or, contact tracing, et cetera. So now you start to see this holistic picture and narrative of the pandemic, not only its effects, but how to proactively manage it.
Great way to end. Thank you, Susan.
Yeah, that was a perfect way to end. Thank you so much to everybody who attended the session today. As I said, the session has been recorded. It will be available online at rootcausecoalition.org/webinars later this week. If you liked what you saw and you would like to present on a future session like this, you can contact me, Rachel Carlson, at rcarlson@rootcausecoalition.org. The contact information for our presenters is up on the screen. If you have any other questions for Root Cause or any of them, feel free to contact any of us. Again, thank you so much to all of our presenters for their incredible work and for sharing it with us. And I hope you all stay safe and healthy and have a great rest of your day.
Thank you, Rachel.
Thank you all.
Thanks all.